All right. Good morning, everyone, and welcome to the Friday academic meeting from the Department of Internal Medicine. It's a pleasure for the Division of Cardiology to present today, something that I'm sure you all treat and manage on your day-to-day practice. And many of our patients, especially in our region, suffer from hypertension, and sadly, despite a lot of therapy being available, this is one of the conditions that's poorly managed, and many of our patients aren't treated to target. Furthermore, even the dilation of the diagnosis, a lot of differences in the various regions, what the Americans say, what the Europeans say, and we follow what the European guidelines say. So for this morning, Dr. Ntila, one of our cardiology fellows, is going to be presenting the latest consensus guideline document from the European Society of Cardiology. This came out from our 2024 Congress, which was held last year. And she'll be giving us some practical tips and making it relevant to our local South African clinical practice. And please, at the end of the discussion, we welcome engagement. And also, I believe those online may post questions. Dr. Viv Naidu is helping us to manage the IT, and we'll hopefully have rigorous discussion. And I think that's very important also for us here at Charlotte. As you know, we don't have a hypertension clinic anymore, and often there's a lot of tension, if I may call it, in terms of where these patients go, how do we manage them, et cetera, et cetera. So again, that will be open up for discussion at the end. Dr. Ntila, thank you for the time and preparation. The floor is yours. Thank you.
Good morning, colleagues. As Prof has introduced me, I'm Dr. Ntila. I'm a fellow in the Department of Cardiology. Today, I'm just basically going to be presenting an update on the hypertension guideline. It is quite a big guideline, about 107 pages. So I've just picked a few topics which I think will be relevant for us. For more detail, I would advise you to refer to the guideline for other specific things. In terms of the background, it is estimated by the World Health Organization that about 1.13 billion people worldwide have hypertension, and most of which live in low and middle income countries. It is estimated that approximately 1 in 4 men and 1 in 5 women have hypertension. And of those patients, fewer than 1 out of 10 have the hypertension under control. As we know, hypertension attributable cardiovascular burden in the young adults over the years has increased in the past few decades, especially in middle and low income countries and in men. Coming to our relevant statistics in South Africa, cardiovascular disease is a leading cause of death, and high blood pressure is a primary risk factor. And the prevalence of hypertension is very high in our setting. However, the control is quite poor, and cardiovascular events occur at younger age compared to patients from Europe and America. Part of that is because of hypertension being called a silent killer. Most people with hypertension are unaware of the problem because it may have no warning signs or symptoms, and a significant amount of people therefore go untreated. And for this reason, it's imperative to have a regular screening as well as public awareness raised. Most of the patients with hypertension have what we call primary hypertension, of which an underlying cause is unknown, and about 10% have a secondary cause. However, some studies quote that as much as higher as 10 to 35% of patients actually have secondary hypertension, especially now with our modern era of systematic screening. And in patients with what's called resistant hypertension, which will come and define later, up to as much as 50% of them have a secondary cause. In terms of the pathophysiology, I'm just going to go over that briefly. It is basically a complex interaction between multiple factors: genetic, environmental, behavioral factors, socioeconomic, interacting with renal mechanisms, neural mechanism, vascular, as well as hormonal mechanisms, which I won't go into detail. And we know that hypertension is a multisystemic disorder. It can affect various organs ranging from the eyes to the brain, to large and medium arteries, microcirculation, as well as the heart and the kidneys, manifesting with different patterns of hypertension, hypertension-mediated organ dysfunction. In terms of screening, so who is recommended to be screened for hypertension? So any adults basically defined to be age of above 18 to 40, if they have a first degree relative, especially two parents with hypertension, it's recommended to screen them every 3 years. And patients who are over the age of 40, irrespective of comorbidities and risk factors, annual screening is recommended. And then the patients that have been found to have elevated blood pressure on screening, which I'll come to define shortly, without requirements or indications for treatment, you can also continue screening them annually until such a time whether they're officially diagnosed with hypertension or they develop indications for treatment. So what are the recommendations in terms of blood pressure measurements? There's a huge emphasis that we use validated and calibrated devices and also to enforce correct measurements as well as techniques. So as to apply consistent approach to BP measurement for each patient. In terms of validated calibrated devices, so now we have these electronic devices that can be used, but it's said that as low as up to 60% of them are actually validated. So before we interpret results from these automated devices, you need to ensure that they're actually validated. And in terms of the technique or measurements, basically in a clinical setting, I think that would be apply more as well to our students and interns. Basically, it's recommended that when you do measure this blood pressure in an office setting or home setting, that the patient should be at least resting for 5 minutes. They should avoid exercise or stimulants for 30 minutes before you actually do the measurement. You sit the patient up correctly upright to make sure they're supported. Their arm is also supported. You choose a correct BP cuff, which is very important. And it's recommended that the BP cuff, basically, they're different sizes and there are indications in the sizes of how to choose a size. But in general, you will measure the blood pressure basically at the midpoint between the acromion and the olecranon. And you should use a cuff size that's about 75 to 100% of that length, and in width 35 to 50% of that. And it should be at the level of the heart. So this is basically, there's a big emphasis to make sure that the results can be reproducible, correct, and validated in terms of that. Even for home measurements, you will still use the same principles. However, out-of-office measurements are basically prepared in particular because they can also detect white coat hypertension as well as masked hypertension, where out-of-office measurements are not logistically or economically feasible, then office measurements may be used. In terms of the new definitions of high blood pressure, so with the new guidelines, we maintain the old definition, which is high blood pressure is defined as an office systolic of more than 140 and a diastolic of at least 90. However, now there's been an addition of a new category termed elevated blood pressure, which is defined as office systolic blood pressure of 120 to 139 and diastolic of 70 to 89. Why this new addition? It's because there's new data now that actually shows that there is increased cardiovascular morbidity in these patients with elevated blood pressure as well. For confirmation, as I stated earlier, home-based monitoring or ambulatory is recommended for confirmation of the hypertension. But if it's not available, then you can do a subsequent office measurement. So for home measurement, the definition of hypertension is different. It's defined as an average blood pressure of more than 135/85. However, for elevated blood pressure, it's still the same category. Okay, there are specific populations that you need to have specific considerations when you're measuring this blood pressure, one of them being pregnant patients. So physiologically, blood pressure tends to reach a nadir at about 20 to 30 weeks of pregnancy before increasing towards 10. And only a few of these automated oscillatory measurements have been adequately validated in pregnancy. And in fact, they can tend to lead to false or erroneously high blood pressures. So it's recommended that we actually use auscultatory measurements with sphygmomanometry in patients who are pregnant. Also, they are giving a class 2A recommendation for home monitoring for patients who are pregnant, but it has not been validated or proven effective yet. Other group of patients is patients with atrial fibrillation, because we have the beat-to-beat variation with the blood pressure. So oscillometric BP monitoring is not always accurate. So it's also recommended that we do manual auscultatory measurements for these patients. There are some devices that are coming out now that basically can cater to this, but they have not yet been validated. And then every patient that basically is being screened for hypertension and diagnosed with hypertension should also, at the time of diagnosis, be screened for orthostatic hypotension, which is present in approximately 10% of hypertensive agents and about 50% of the elderly institutionalized patients. And basically the diagnosis of orthostatic hypotension basically is a drop in blood pressure of a systolic of 20 or more, or diastolic of 20 or more after standing from a supine position. Patients with orthostatic hypertension have a high risk of morbidity because they have a frequent risk of falls. Okay, so once we have screened patients, they have either elevated. Once you've screened the patient, you can categorize them into non-elevated blood pressure. We avoid using the term normal blood pressure because they've actually noted that even blood systolics of over 90 do increase worse cardiovascular outcomes. So there's no such thing now as a normal blood pressure, but treating those patients, however, does not show to improve cardiovascular outcomes. So now we define it as non-elevated, which is less than 120/70, and then elevated, which is 120 to 139/70/89. Then hypertension. Then for those that, when you screen them, have elevated blood pressure, we'll put them in 3 categories. We no longer use stage 1, stage 2, stage 3 hypertension as per previous guidelines. Now we categorize into BP 140, 159, 160, 179, and more than 180. So after you've had this initial screening blood pressure, then you need to ideally have a home measurement for confirmation, or ambulatory measurement for confirmation. And that should be ideally done within 1 month for patients in this category. And in patients with this category of 160 to 179, 100 to 109 as well, they also recommended to repeat it within a month of that. And the patients that fall under the category of more than 180, 110, which is severe hypertension, you need to then rule out or evaluate them for hypertensive emergency. So those that basically just have severe hypertension, you can bring them back in a week's time to confirm the diagnosis of a hypertension. It is so that you can exclude extreme white coat hypertension. So then if you do confirm it a week later, then you can start them on treatment. However, those who have hypertensive emergency, they will be treated differently. So how do we define hypertensive emergency? So it's severe hypertension that is associated with a hypertension-mediated organ dysfunction, often in the presence of symptoms. These conditions are potentially life-threatening and they require immediate and careful intervention to reduce the blood pressure, and we often use intravenous therapy to do so. So the symptoms will depend on the organ dysfunction. They may range from headaches to visual disturbances to chest pain, shortness of breath, and dizziness, or neurological deficits. So how can patients manifest with the organ damage? So it basically goes back to the slide that I put up with the hypertension mediated organ dysfunction from the different organs. So it can present that way, or it can present as a malignant hypertension, which is defined as an extreme blood pressure elevation and acute macrovascular damage. So these patients often will present with DIC, with papilledema, as well as renal dysfunction. Other manifestations could include patients in a setting of a patient with a pheochromocytoma who comes with a pheochromocytoma crisis. So principles of management, besides the normal ABC to stabilize the patient, now you have to establish the affected target organ, whether they require any specific intervention as well, despite just lowering the blood pressure. And then to determine if there's any precipitating cause for the acute episode and whether there are any concomitant healthcare conditions that might affect the treatment plan. For example, pregnant patients will be managed differently. And also the recorded timing and magnitude of BP lowering required, whether you need immediate lowering or over gradual lowering over time, it will depend on the organ dysfunction. So all these principles will inform the treatment that is required. So we use intravenous drug because they have quick onset of action and they have a shorter half-life as well. And they do allow careful titration of the blood pressure. We should avoid rapid, uncontrolled, excessive lowering because we can have complications from that as well. For approach a patient who comes with any hypertensive emergency, this is a diagnostic workup that you can do initially on the bedside. You can do fundoscopy, urine dipstick, as well as a 12-lead ECG. Some of the investigations might be directed by the organ dysfunction the patient is presenting with. So you might need to do, oops, not sure what I pressed there. So you might need to check for hemolysis if you're thinking malignant hypertension, renal function, as well as urine ACR, pregnancy test for women. If you think there is myocardial ischemia, then you can do your cardiac enzymes, some chest x-rays to echo if needed. If you think aortic dissection or heart failure or ischemia, as well as CT angio in a setting of aortic dissection and CT burn in a setting of a stroke or bleed. Renal ultrasound might be necessary in a correct context. If you think the patient has suspected renal atherosclerosis, as we know, they can also come with flash pulmonary edema and drug screen for patients who are IV drug users. They can also have a hypertensive crisis from withdrawal or during the intoxication. So basically, these are the medications that are available for blood pressure lowering. For us, really, we usually have labetalol available as well as nitroglycerin in terms of which drug to choose. So usually labetalol, except in few contraindications where patients have heart blocks, they have acute pulmonary edema, severe LV dysfunction or asthma or AV blocks. In that setting, then you can use nitroglycerin. Just beware of the side effects. So in terms of patients who come with an acute intracerebral hemorrhage, so increased blood pressure in these patients is associated with hematoma expansion and worse prognosis. So in trial testing, immediate BP lowering within 6 hours to a systolic target of less than 140. The achieved systolic blood pressure in the intervention group basically group was typically 140 to 160 and was reported to reduce the risk of hematoma expansion. So lowering the blood pressure within 6 hours to about 140 to 160 in these patients is acceptable. And we must avoid excessively lowering the blood pressures from systolics above 70 acutely, because they can also develop an acute ischemic episode from that, as well as renal injury. In the setting of patient who comes now with a acute ischemic stroke, it's going to be different. In these patients, it's really uncertain in terms of the benefit of lowering the blood pressure. However, then you can group them in patients who are going to receive thrombolysis and patients who will not receive thrombolysis. If a patient is not really receiving thrombolysis or thrombectomy, there is no evidence for actively lowering the blood pressure unless it's extremely high, over 220 over 120. And even those with extremely high blood pressure, you can aim for relative initial reduction of about 10 to 15% over a period of hours. However, for those that are going to basically be thrombolized, because we know that there is a relative contraindication, severe blood pressures to thrombolysis, so you will then need to lower the blood pressure for those to less than 185, 110. And then in patients with acute strokes who have BPs over 180, 105 from the onset, in the first 70 hours, it's not recommended to lower that blood pressure. So you can admit the patient, observe them. If it's still elevated after 3 days, then you can start antihypertensive medication before discharge. Okay, what about stable patients? So who qualifies for treatment for stable patients? So we have two groups here. We have patients with confirmed hypertension. All of them will require treatment, whether it's lifestyle as well as in addition pharmacological. Then we have patients with a group elevated blood pressure, which we defined earlier. For those patients with elevated blood pressure, it will depend on their 10-year cardiovascular risk. So basically, anyone who is over the age of 40, basically, we can do a SCORE2 calculator to assess the 10-year cardiovascular risk. If it's more than 10%, then we treat those patients. And then for elderly patients, we can use a SCORE2 elderly person score. Then similarly, if it's more than 10%, you treat. There's also one specific for diabetic patients, SCORE2 diabetes. Also over 10%, you treat those patients. Now the gray zone comes with patients who have the intermediate scores. They have elevated blood pressure and intermediate scores. So those patients, you have to consider additional things that we call basically hypertension risk modifiers. I'm gonna come to them now. So one of those basically is patients who have very high risk. So those patients are either already having established atherosclerotic cardiovascular disease, they've had previous MIs, previous strokes. Those are deemed very high risk and should be treated. Patients with familial hypercholesterolemia in that group as well. Patients with moderate to severe CKD are in the very high risk group, so they should also be treated. And then the patients who do not have those very high risk conditions, then you need to look at risk modifiers, their family history. Are they high risk population group, which they've termed as the Asian patients? Do the patients have any hypertension mediated organ damage, maybe LVH, for example, retinopathy? Then those ones will need to be treated. And then if patients don't fall with those, you can also use extra investigations. For example, things like carotid Dopplers of the femoral arteries, looking for atherosclerosis. We can use calcium scoring from coronary CT if they have score of more than 100. So those patients are deemed high risk. You can use that. Patients with previous gestational hypertension as well, those are termed risk modifiers. So you can consider treating those patients even though they just have elevated blood pressure. So in terms of the management of patients who are stable, so initial clinical and biochemical evaluation to diagnose and delineate factors potentially contributing to hypertension, to identify other risk factors as well as relevant comorbidities, and to screen for secondary causes. So everyone over the age of 40, we have a class 2A recommendation to actually screen for a secondary cause. But for patients who are under the age of 40, it's a class 1 recommendation to screen for a secondary cause. So it's important that patients understand the chronic nature of hypertension, and it's key to ensuring long-term engagement with medical treatment. So we know that a lot of our patients are not compliant on medication. So it's very important from the beginning for the patients to understand the chronicity of their condition, as well as cardiovascular outcomes or adverse events that can come from poor management of that condition. And it's basically objective methods to assess adherence are actually also advised. I don't know if we have available. They do recommend things like not just pill counting, but also doing urine drug level tests. I don't think that we have that available. So objectively for physicians to screen for compliance is very important. So these are the tests that you can do initially to look for other associated cardiovascular conditions. This is what I've stated in terms of screening for secondary causes. And in terms of management, you have lifestyle management and we have pharmacological management. So what's recommended for lifestyle is increasing potassium intake has been basically deemed beneficial as well, except in patients that have CKD. They do recommend that patients who are on potassium sparing drugs, that you need to be very careful when you do that. Increase physical activity to at least 150 minutes a week, moderate to intense aerobic activity for patients who are obese to optimize the weight, as well as reduced intake of sodium to less than 5 grams a day, and to reduce alcohol. In fact, no alcohol at all is recommended, and to stop smoking. Okay. So in terms of pharmacological management that we have, first recommendation, so there's now the move towards recommending starting a patient on multiple agents from the beginning. So what now we called polypill or drug combinations. So we can use a drug combination or other ACE or ARB with a calcium channel blocker, a diuretic, either thiazide or thiazide-like diuretic is a class 1 recommendation. Then you reassess the patient in about 1 to 3 months. If they're still not controlled, you can either up-titrate those doses, or you can up-titrate those doses or add a third agent if you only used 2 in the first setting. Reassess them again in 3 months. Once the patients have been on maximum doses of ACE or ARB, calcium channel blocker, diuretic, they're still uncontrolled, then you can consider at that stage, basically at that stage, that's what defined as resistant hypertension. Then you can work up for a secondary cause, make sure the patient is adherent, exclude white coat hypertension. Those are patients that ideally should have ambulatory blood pressure monitoring to make sure that it's not just in the office setting that the blood pressure is elevated. It is truly indeed elevated. So from that point onwards, now you can add spironolactone is a class 2A after you've excluded secondary causes. Then you can add spironolactone and also a beta blocker. If there's any compelling indication from the beginning, you would have added as well, and you would refer those patients for further workup. Okay, in terms of drugs, this is a general, this is basically a general recommended, but we know that there are some hypertension-mediated organ damage where specific drugs have been shown to have mortality benefit and improve cardiovascular outcomes. So you need to also consider that as you are prescribing these medications. For example, patients with diabetes, ACE inhibitors are basically preferred, or patients with metabolic syndrome, ACE, ARB, calcium channel blocker, and patients with CKD, also with proteinuria, ACE inhibitors, ARBs, diuretic, as well as SGLT2 inhibitors. But also now we have the MRAs such as finerenone as well, which can be considered. If a patient is post-MI, beta blocker, ACE inhibitor, ARB, and MRA, and in AF, beta blocker, ACE inhibitor, or ARB as well, and in heart failure, the 4 pillars basically of heart failure management, including diuretic there. It's important to know the contraindications of these medications as well as side effects for these medications as well. What about pregnant patients? So patients who are pregnant, hypertension can be categorized in 3 ways. In these patients, they can be diagnosed as chronic hypertension if it precedes the pregnancy, or if it develops before 20 weeks of gestation or after, and it persists beyond 6 weeks postpartum. And it's called gestational if it develops after 20 weeks, and it usually resolves within the 6 weeks postpartum. And then there are those patients who fall in the gray zone, who are antenatally unclassifiable. You find that they have blood pressure maybe after 20 weeks, you're not sure when it started. These patients, however, you need to check them after 6 weeks whether it resolves or not. If it doesn't resolve, they will fall under the category of chronic hypertension. If it results in retrospect, gestational hypertension. And then there's a category of preeclampsia, which is basically gestational hypertension with proteinuria and maternal organ dysfunction, as well as fetal organ dysfunction. How do we prevent gestational hypertension? It's important to identify women who are at risk, who are high or moderate risk. And those women should be advised to take aspirin 100 to 150 milligrams daily at about from 12 weeks to 36 weeks. Show that also oral calcium supplementation is recommended as well. And then also low to moderate intensity exercise, but under supervision can also be recommended. How do we diagnose it? So it's also the same definition of more than at least 140/90. However, in this instance, the readings should be taken more than 50 minutes apart. In a normal patient, you would do 3 readings, 1 to 2 minutes apart, and you would take the last 2 and average them. So it's important to also consider a secondary cause in young women as well. And in terms of acute management of preeclampsia, so we know that in the acute setting, delivery basically is the treatment of choice. However, you need to lower the blood pressure before that to stabilize the patient, and it should be ideally lowered within 150 to 180 minutes to less than 160/105. So the options that we can use that are recommended in pregnancies are vilabetalol and or nicardipine, which we do not have, together with magnesium sulfate. Also, oral medication from the calcium channel blocker, nifedipine, can also be given. However, we need to be careful as co-administration can potentiate hypotension in these patients. If BP control is not achieved within 360 minutes despite 2 medications, then critical care is recommended. And it's imperative to avoid diuretics in these patients because they already have reduced plasma volume. In terms of treatment of patients with pregnancy-induced hypertension, so patients who have BP of more than 140/90, it's recommended to reduce the blood pressure so that they do not progress to severe hypertension. It's a class 1 recommendation. And those with severe hypertension, basically, we know that they have very poor, they can have adverse maternal as well as fetal or perinatal outcomes. And women with gestational hypertension, with or without preeclampsia, they recommend lowering the blood pressure to 140/80/90. So there's really no evidence to show there's benefit in going beyond that in patients who are pregnant, unlike the general population. In terms of drugs that we can use in pregnant patients, RAS inhibitors are not recommended in pregnancy due to adverse fetal and neonatal outcomes. However, beta blockers may be used, and the beta blockers that have been shown to be safe are those with vasodilatory effect, like metoprolol, labetalol, bisoprolol. Atenolol is not advised. It's actually contraindicated in pregnancy. And other calcium channel blockers as well, dihydropyridine ones such as nifedipine is recommended, and it's the most commonly used. You can also use methyl dopa, but bear in mind that it actually increases the risk of postpartum depression. So you need to monitor for that. Thyroxine diuretics may be used. We have very limited safety data, so they should be used with caution. And also to remember counseling for future pregnancies, that 20 to 30% of patients who develop gestational hypertension have a risk of developing it in subsequent pregnancies as well. And the last point is contraception. So women with basically gestational with hypertension, it's advised that you avoid using combined contraception with estrogen and progesterone, and rather use progesterone-based contraception as well. Okay, so this also in terms of patients who are breastfeeding, we can still give these medications to them. ACE inhibitor like enalapril in our setting, we can give them calcium channel blockers. Beta blockers are also safe as well as diuretic. Now, in terms of patients that you've put on the 3 optimal treatments, calcium channel blocker, ARB, ACE, as well as diuretic, the maximal doses, they're still not controlled in terms of the blood pressure. Those patients are basically termed as resistant hypertension. The caveat to this is patients with CKD, you need to make sure they're on optimal high doses of diuretic before you deem them as resistant hypertension. So as I said earlier, up to 50% of these patients have a secondary cause. So they need to be screened for secondary cause. Also, you need to confirm that they indeed have resistant hypertension. They are adherent to treatment, do ambulatory blood pressure monitoring to check their home-based measurements as well. So these patients will know that they're very high risk of having adverse cardiovascular events, actually as high as 2 to 6 times than the normal patients. So it's important to treat them timeously. These are the tests that you can do to screen for secondary causes. One of the commonest ones being primary aldosteronism. It's said that it's actually prevalent up to 12% of patients with resistant hypertension. Renovascular hypertension in a setting of a appropriate patient, whether it's a young patient, especially female, you need to consider fibromuscular dysplasia, or a patient who's elderly, who keeps coming with flash pulmonary edemas, with atherosclerotic risk factors, you need to consider renovascular disease from atherosclerosis, and also pheochromocytoma in the right context, obstructive sleep apnea in patients who are obese. Also, it is one of the commonest causes of resistant hypertension. Then you can consider other causes that are not so common, Cushing's, hyperparathyroidism, coarctation of the aorta. This should have perhaps been picked up from the initial assessment. When you see these patients for the first time, you diagnose them with blood pressure. It's recommended that you actually do the blood pressure in both arms. If there's a difference of more than 10 millimeters, then you can consider possible coarctation and you can work them up further. So as I said earlier, how do we manage patients with resistant hypertension? So exclude a secondary cause, make sure it is indeed resistant hypertension. Then you can add aldosterone. It's a class 2A recommendation. If they're still uncontrolled, the beta blocker, especially if there is a compelling indication. Patients who are intolerant to spironolactone, then you can consider the non-steroidal MRA, which is the finerenone, or eplerenone as well, you can consider. If patients are not responding despite these maximal treatment, you've put them on central acting agents as well, which is the last resort, either methyl dopa, doxazosine. Then you can consider other non-pharmacological measures like renal denervation, which is a class 2B recommendation. So in terms of the device-based blood pressure lowering, we have renal denervation. It is not recommended to be the first line of treatment because in fact, it actually has a very modest blood pressure lowering properties by 6 millimeters, which is lower than the 3 initial combination therapies that you've studied. So it's only recommended in patients with resistant hypertension at the moment. Other devices that are coming to play, modulating autonomic nervous system activities and endovascular baroreflex application therapies, but they haven't been validated yet. So how do we follow up the patients? So every 3 months, and ECG as part of the initial workup. And if there's any evidence of LV dysfunction or LVH, you can send them for echo if it is recommended. That is, if they have abnormal MEMA or they have symptoms. Okay, and those who have moderate to severe CKD, it's recommended that you repeat the EGFR and creatinine and urine ACR at least annually. Long-term monitoring, home-based and ambulatory monitoring is preferred than office measurements. In conclusion, epidemiological studies demonstrate that there's a continuous and a long linear association between blood pressure exposure and adverse cardiovascular outcomes. So therefore, strict blood pressure lowering generally improves the cardiovascular outcomes, with the exceptions of patients who are elderly, frail, or patients who have limited life expectancy, or those patients who do not seek the tight targets that are recommended of 120 to 130 over 70, 80. Thank you.